Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss a case of vertigo. So shall we start?
Yes.
A 45-year-old lady, no previous comorbidities, presents to the ER with sensation of spinning of the surroundings. Coming to initial 10-second assessment, the patient was conscious, oriented and obeying commands. Coming to the primary survey, the airway was patent, no hoarseness, no gurgling or stridor. Coming to breathing, respiratory rate of 20 per minute, saturation of 95% in room air. Circulation pulse rate of 110 beats per minute, BP of 140 by 90 millimeters of mercury, all peripheral pulses equally palpable. Coming to disability, GCS of 15 by 15, pupil bilaterally equally reacting to light. Coming to exposure, temperature of 98.2 degree Fahrenheit and GRBS of 180 milligram per liter.
So here primary survey is fine. This patient, your 10-second assessment, you are clearly telling patient is conscious, oriented and is obeying command. So you know that dosely the neurological system and patient is in fact stable. So fine, all these are fine. But in coming to disability, now we are dealing with a patient who is saying that she has a spinning motion while sitting or lying down or whatever. She have a spinning motion. So we are dealing with something neurological, maybe peripheral, maybe central, but something neurological. In that case, in disability itself, you can ask for movement of extremities. Now, disability not only says about generalized GCS of the patient and pupils, but you can also test for extremity movements. So in this patient, if you ask for extremities to move all four limbs, just mild movements, and patient is not able to do one half of the body, then we immediately are alerted that we are dealing with a probable acute CVA event, because patient has loss of balance, some spinning movement is there, and unable to move one upper limb and lower limb. We can directly think that patient most probably has a CVA. Okay.
Coming to adjuncts of primary survey, ECG was taken showing a normal sinus rhythm. PBG was taken showing no acute acid-base disorders.
Similarly, we have to look for a GRBS also, right?
GRBS and the exposure we have.
Oh, we have checked in the exposure.
Coming to the sample history, a 45-year-old female, no previous comorbidities, presents to the ER with complaints of spinning sensation of the surroundings of 1 day duration. It was acute on onset. It started when she was trying to walk up from bed. There were multiple episodes lasting for few minutes and it worsens on the left lateral position. There were no history of diplopia, weakness, swaying, headache, dysarthria, hearing loss or tinnitus. No history of any allergies, history of similar illness in the past, no similar illness in the family. Coming to general examination.
Similarly, trauma history. Trauma also we have to ask. Okay.
Coming to general examination, no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy or no pedal edema. Coming to systemic examination, CNS, the higher mental functions were normal, all cranial nerves were normal, tone were normal, power 5 by 5 on all four limbs, cerebellar signs, nystagmus were present, bilateral, other tests of cerebellar signs were normal. Special tests, Dix-Hallpike maneuver, left side turned out to be positive. Coming to other systems, GIT, soft non-tender bowel sounds plus no organomegaly, respiratory system, normal vesicular breath sounds, no added sounds, CVS examination S1, S2 plus no murmurs. Coming to our final diagnosis, benign paroxysmal positional vertigo involving the left posterior semicircular canal.
Okay. Okay.
This is the anatomy of our ear, and posterior semicircular canal is the most dependent area in the inner ear, and otolith is most 95% of the cases is launched into the most dependent part, that is the posterior semicircular canal. Coming to diagnosis of Dix-Hallpike maneuver, Dix-Hallpike maneuver mainly differentiate positional posterior semicircular canal and the lateral semicircular canal. If the posterior and the lateral semicircular canal is involved, then Dix-Hallpike maneuver tends out to be positive. The procedure is done and the patient's head in sitting position, the patient head is rotated to a 30 to 45 degree, and then the patient head is then put to the supine position at the vantage point, and we will keep that position for about 30 to 60 seconds and observe for nystagmus. In posterior semicircular canal is involved, there will be vertical nystagmus that is present. Nystagmus can be present in both central and peripheral causes.
Yes.
But in central nystagmus, the direction of nystagmus will only have a torsional component and also a vertical component. Whereas in peripheral nystagmus, there is only vertical component. And on optic fixation, in central nystagmus tends to be does not disappear on optic fixation, whereas peripheral nystagmus it will disappear on optic fixation. And also central nystagmus is a direction changing nystagmus, whereas peripheral nystagmus is always unidirectional. Coming to the causes of vertigo, central and peripheral causes are present. Coming to central causes, vestibular migraine, brainstem ischemia, cerebellar infarction and hemorrhage, and Chiari malformation. Coming to the peripheral causes of vertigo, the most common cause is BPPV, following that vestibular neuritis, herpes zoster oticus, Meniere's disease, labyrinthine concussion, perilymphatic fistula, semicircular canal dehiscence, Cogan syndrome, recurrent vestibulopathy, acoustic neuroma, aminoglycoside toxicity, and otitis media.
So we need to think about aminoglycoside toxicity and otitis media also, because we deal with many of the infective patients. So patients can present with acute nystagmus and vertigo. So drug history for aminoglycosides should be asked around. Similarly, otitis media is one of the most common diseases out there. Patients coming with nystagmus, patients coming with vertigo is not very common, but otitis media being common, one of the commonest causes of vertigo should be thought as otitis media, and that should be ruled out before proceeding further.
Coming to the drugs that are used in vertigo, especially in BPPV, prochlorperazine is used. It blocks the D2 dopaminergic receptors in the brain. The usual effective dose is in the order of 75 to 100 milligram daily. The other drug uses beta-histine dihydrochloride. It has two modes of action. Primarily, it has a direct stimulating agonistic effect on H1 receptors that is located on the blood vessels in the inner ear. It also acts on the stria vascularis of the inner ear, thus reducing the pressure in the endolymphatic space. Dose is initially 16 mg 2 tablets thrice daily taken, following which we will taper the dose according to the clinical response. Coming to supine roll test, for horizontal semicircular canal, Dix-Hallpike maneuver is less sensitive and supine roll test is done. Here the patient is put in the supine position. Suddenly the patient is rotated 90 degrees to one side and keep it for 30 to 60 seconds and look for nystagmus. If no nystagmus, then the head is turned to the neutral position, and then the head is quickly turned to the opposite side, and then again wait for 30 to 60 seconds, and if nystagmus is present, then it is involving the horizontal semicircular canal. Coming to the treatment of BPPV, Epley's maneuver is done. Initially, the head is turned 45 degrees to the affected semicircular canal. Then keep the head turned and lay the patient down and extend the neck 10 to 20 degree if the patient is able to do, and keep that for 30 to 60 seconds. Then the head is turned 90 degree towards the unaffected side. Then turn head another 90 degree by rolling the body towards the unaffected side, and later sit the patient up while keeping the head turned and neck flexed. Each of these positions must be maintained for at least 30 to 60 seconds. So finally summarizing, vertigo can be of two types. We have to detect it as central or peripheral causes. First, initially from the history, central causes, there will be cranial nerve involvement, there can be diplopia, blurring of vision, ataxia, weakness can be present. Whereas in peripheral causes, there is no involvement of the cranial nerves, and depend on the history. If vertigo multiple episodes lasting for few minutes and on changes with the position, it probably with similar illness in the past probably point towards BPPV. If there is vertigo with any cuff or postural variation, you have to suspect about superior semicircular canal dehiscence. If there is vertigo that is associated with loud sounds, that is Tullio phenomenon, we have to think about Meniere's disease if there is any associated hearing loss also. Then after history, we will come to examination. Examination wise, if the cranial nerves are intact, cerebellar signs are intact, then probably we will deal with the peripheral causes. And based on the nystagmus, we can differentiate between central and peripheral. But in ER settings, it might not be able to differentiate the minute thing about nystagmus. Usually, if the nystagmus is central and peripheral, if central nystagmus, it is always direction changing and it does not disappears with optic fixation. Whereas peripheral nystagmus is not direction changing and it disappears with optic fixation. There is no torsional component associated in peripheral nystagmus. Then coming to our special test like Dix-Hallpike maneuver, it can be positive in the case of BPPV, but horizontal and lateral canal involvement is only detected by Dix-Hallpike maneuver. Whereas supine roll test, if done, it came out to be positive, then it detects that it is the horizontal semicircular canal that is involved. And finally, the treatment of, if it is BPPV, the treatment will be Epley's maneuver that is shown in the figure. If it is a central cause, then here we have to look for CVA, suspecting CVA, we have to go for MRI.
No, that is the question. So this, when a patient who has vertigo presents to ER, how do you approach the patient? You have done the investigation, you are suspecting it is to be BPPV, you have done the Hallpike's maneuver to confirm it, but it's negative. You are not getting a positive results there. How will you proceed then?
Basically, sir, it is the time that is important. If the onset is very acute and within the window period, and we are not able to make a clear-cut picture whether it is central or peripheral, or if the patient is having severe acute vertigo, so that we are not able to elicit the examinations, we are not able to do the examination properly, then as an emergency scenario, we have to take an MRI and rule out the CVA.
Yes, so posterior circulation stroke should be ruled out, but that's not for everyone. In such a scenario, we need to select the patient and think what comes. The risk benefit ratio should be thought about. So if it is an elderly patient already having vascular thrombotic history previously, CAD history, or previous CVA is there, or previous thrombotic spontaneous thrombotic events are there, those are high risk patients. Similarly, elderly males, elderly females with diabetes, dyslipidemia, hypertensive comorbidities, those are prime candidates to develop a cerebral vascular abnormality. And those kind of patients, when they present with acute vertigo, we need to think, are we dealing with a CVA or not? That's why initially we told we should look for extremities, whether any movement or sensory deficits are there. If no motor deficits, sensory deficits, and we are dealing with only a vertigo, it's very unlikely that a CVA is causing only vertigo. It's very unlikely. But then also we have to suspect a posterior circulation stroke. So proper examination of the patient is very important. Always rule out the most common conditions that you have already taken care of. But if you are not able to come to a diagnosis with Hallpike's maneuver or supine test, supine roll test, then you should suspect yourself whether you are dealing with a CVA or not. So other electrolyte abnormalities and hypoglycemia should be ruled out. If everything is ruled out, we should talk with the bystanders and let them know there is a possibility of a CVA and go for MRI, especially in a high risk patient. Okay. Okay.
Thanks.